Good morning and welcome to another Connecticut Health Council program. We are absolutely delighted to have with us this morning Dr. Reed Tuckson, who's taken time out of his calendar to be with us and talk, as the title says, about the evolving healthcare landscape. So welcome to all of you. Jim Bedard from United Healthcare, representing both United Healthcare and Optum, will be up here shortly to introduce Dr. Tuckson. And Amy Cunningham, who's the executive director of the council, will be up at the end of Dr. Tuckson's remarks to make sure you know about what's on the calendar in the remaining months of this year. I want to thank the Marriott for hosting the event this morning. Delighted to be here again at this facility. As I say, I want to thank United Healthcare and Optum for their sponsorship this morning and for their leadership in the Health Council and a number of other initiatives, and I'll mention those in a second. Particularly want to thank Craig LaFiandra from United Healthcare, who was instrumental in working with our team, with Amy and Brian Boyer and others, in making today possible. So Craig, thank you very much for your support on that. We also want to acknowledge the Hartford Current Media Group and the Fox Connecticut Media Group for their continued media sponsorship of today's program. Just briefly, before I acknowledge a couple of new founding partners of the council, for those of you who are attending your first council event, council program, the purpose of the council is to ensure that there are more people in this state who understand the breadth and depth of the extraordinary health assets that we have here in the state of Connecticut, and that we're in a better position, individually and collectively, to promote this state as a center of health excellence. All looking forward to this sector being a continuing driver of employment and economic growth. So we're delighted to have you here if you're here for the first time, and certainly thank all of you who have been here in the past. We do have two new founding partners, and if you're interested, if you're not a founding partner, would like to become one and become more engaged with the council, please see Amy or Nancy Wheeler or me after this, or simply go on the Connecticut Health Council website. The two new founding partners that we're recognizing is 6 Point Creative, 6 Point Creative and OFI. So I don't know if there's anyone from either of those organizations here this morning. They've come on as strategic partners of the Alliance and have also engaged as a founding partner, but we want to thank both of them and ask you, whether they're here or not, to join me in a round of applause. Welcome them as founding partners to the organization. I think we're going to scroll up, should scroll up after this, the current list of founding partners, which is pushing, I think we're over 90 now, and going back to when we started the initiative 2 years ago, under really Bob Patricelli's encouragement, modeling this off of what we found and what we know to exist in Nashville. We have gone a long way. So those of you who have been with us from the beginning, those of you who are new as founding partners, we thank you for that. Certainly also want to acknowledge Marty Gavin, who along with Bob continues to lead our effort in the Health Council, and Mickey Herbert, who has been good enough to be instrumental in making sure that particularly companies, hospitals, and others in the health sector in Fairfield County are aware of what we're doing. So without further ado, it is my pleasure to introduce Jim Bedard, who is representing United Healthcare and Optum this morning. Jim has been a great friend of this organization, of the Alliance and the Health Council, for a long time, and he, like so many others at United Healthcare, have been instrumental with us in helping us lead the charge on economic growth, ensuring that this region competes for jobs, capital, and talent. Mike Mateo, one of his colleagues, chairs the Alliance Board, and Jim, in addition to being here this morning on behalf of the Connecticut Health Council, chairs our Insurance and Financial Services Cluster, and has done so for the last couple of years, has been provided invaluable leadership in a couple of key initiatives, including the Insurance Market Forecast, which will be our third one this year on November 20th. So it's a great pleasure to have him here. He will introduce Dr. Tuckson. You're in for a real treat, I can assure you of that, in terms of Dr. Tuckson's remarks, and then he'll take questions after his remarks, and we'll go from, and then Amy will make sure you know what's going on from in the last couple of months of this quarter. So please welcome to the podium Jim Bedard, the Chief Financial Officer of United Healthcare.
Good morning, everybody. Great turnout. Thanks for coming out this morning. And I guess just the Patriot fans, all of us look well rested this morning since we got to go to bed at halftime last night. when Oz was saying a real treat, I was getting nervous. I thought he was talking about me, but I'm honored to be here this morning, and we at United Healthcare and Optum are just thrilled to be partnering with the Healthcare Council to sponsor today's event. It's to me, it's such an important topic, and not one that resonates with just United Healthcare and the 4,200 employees that we have in the state, or the over 500,000 Connecticut residents that we insure, or the business partners and clinicians that we partner with. It's really important for all of us, whether you're a patient, a clinician, a small business owner, an insurer. It's really important that we all understand the role that we play in reshaping the healthcare landscape. It's really critical to all of the work that we do. If you look at United Healthcare and Optum, we've modeled our whole business around modernizing the healthcare system. So our United Healthcare businesses are really aligned to provide benefits to individuals and employers of all sizes, community and state and the Medicaid population, our Medicare and retirement serving the senior sector, our military and veterans really serving our servicemen and women, and then we shift over to our Optum businesses, and really that's trying to make the healthcare system work better for all of us. And that's through our clinical programming that we do in Optum, our pharmacy benefit management that we do, all of the data and informatics that we provide, and then also the technology platforms. And some of those are tools that help people make better decision support, or larger platforms like some of the work we've done with healthcare.gov. So really important across the full landscape. But I also think beyond our business model, it's a lot of the work that we do that drives our community giving philosophy. That's all around healthy families, child health, health literacy, and programs like that. And just, I guess, a quick thank you. Yesterday we had our United Healthcare Children's Foundation golf outing. That was probably, I think, the fourth one that we've done in Connecticut. And we had a great turnout over at Lake of Isles. So I do want to say thank you to the Metro Alliance for really helping us market that over the last couple of months and raise the awareness of that foundation here in Connecticut. I also want to thank many of the folks around the tables today that stepped up, either came out or helped and sponsor. And if you feel like you didn't, see me after. We're taking early registrations for next year as well. But I do want to say thank you for that. Our United Healthcare Children's Foundation offers medical grants to children where traditional insurance coverage may not meet the need. So it's really a great program. Across the Northeast, last year we've given out almost $1 million in grants, and here in Connecticut, about 100,000. So excuse me. So yesterday's event, I think, raised probably a little over $90,000. So it helps us replenish the coffers for that money to stay local and to be given out for future grants. So again, thank you very much. Okay, so as Oz was talking about, one of the charges of the Connecticut Health Council is to really engage the thought leadership to position Connecticut to be that center of health excellence. And when you think about where Connecticut sits with all of the assets that we have here, with the great teaching institutions, the great hospital systems, we have all of the major payers here. I think every large insurer has operations here in Connecticut. We also have a great foundation for some of the clinical capabilities as we're starting to build out our research and innovation footprint in the state. So it's really about now that we have all those assets, how do you link them together and how do you get them mobilized? And really, who better to help us think through some of that than Dr. Tuckson, who spent over 35 years as a health professional across various sectors. He's one of the 50 most influential physician executives in healthcare by Modern Magazine, or Modern Physician, for his work across insurance, nonprofit, the government sector, and academia. He's a former commissioner of public health for the District of Columbia, He served as the Senior Vice President of Professional Standards for the American Medical Association. Previously, he was the Executive Vice President and Chief of Medical Affairs at United Health Group and a member of the Executive Operating Committee, and also oversaw the UHG Foundation. Dr. Tuckson is currently Managing Director for the Tuckson Health Connection, a health and medical care consulting business. He founded Tuckson Health Connections to improve people's quality of life, and I think you'll sense he's got a real passion for that. You know, his vision was really to assemble those assets that were available to really engage the best healthcare behaviors and sharing of innovation for both prevention and medical care delivery. So a vision that's very common to what we're trying to do with the Connecticut Health Council as well, so one we all share. So I guess without further ado, you're in for a real treat. Please welcome Dr. Reed Tuckson.
Thank you. What a terrific place to be. I was excited to be with you because it didn't take really much to realize the kind of firepower that's in this room. When we think about what's at stake, whether or not the people who share our time and space shall live, or whether they shall prematurely die, and the quality of that survival, there is nothing more important than harnessing every bit of energy, every bit of talent, every bit of genius together to fight for things that are really important. And this is really important. So to hear that the great state of Connecticut is trying to really use all of its firepower in a more harnessed way is terrific. When they asked me to speak on something that had to do with the context of collaboration, I got really excited. Lord knows, this stuff is hard, and there are no easy solutions. Lord knows that each of us have our own organizational or industrial self-interest. But one thing that is unarguable, we're human beings. And whether or not as human beings we get the chance to be healthy or not is really what this is all about. The landscape for healthcare, I wish it were so simple. I wish we could just go following down the yellow line in the middle of the road. But we are living in the messiest, most complex time ever in the history of healthcare. It is a time of volatility. It is a time of unstableness. It is a time of risks, but because we are private sector-oriented people here, this is a time of opportunity. And I think that that's really what's key, is that we come to these challenges really thinking about the opportunity for translating relentless change into insatiable innovation. And that's what gets me sort of up in the morning. Within all of this, complex decisions have to be made, and we have to be prepared to make those very difficult choices. The changes that we are seeing that are so messy in the scientific foundations of clinical medicine, translation of innovation into diagnostics and therapeutics, the epidemiology or the experience of illness, the aggregation, analysis, and application of big data, care delivery, organization, and reimbursement, new consumerism in healthcare to start to mirror other industries, and then this final overarching need for the first time in healthcare to deal with value. All of this is churning. I wish I should have done this slide in a different way. Instead of them coming up linearly, sequentially, I should have had them just scatter all over the board and not look so clean and neat. But at the end of the day, continuous evolution is the hallmark. Private sector leadership has been absolutely key, and that's why I'm so glad to be sort of with you. I went back the other day, about a year ago, less than a year ago, November. This was the dominant news of the day. Medicare raising payments based on quality measures, and then what we're finding, though, is that 1,500 hospitals were penalized under this rating program. And what got me was the bottom of the article, which says, renewed focus on excellence in the areas that are being judged. And I thought about that for a minute, and I went back and I looked at the history of leadership by the private sector in healthcare. And it really, in many ways, conveniently starts with companies like GE, Motorola, Allied Signal starting to get to Six Sigma engineering back in '95. And they started to use that and moved it into healthcare in something in '98 called the Leapfrog Group. And this Leapfrog Group was the beginning of real organized firepower by the private sector community to saying that we are getting sick and tired of the dysfunction in healthcare that we are paying for. We want to now see a different kind of engineering processes. And so they create the Leapfrog Group. Immediately on the heels of that was this landmark report which changed everything. This is the To Err Is Human report, which told us for the first time transparently the number of Americans that were being killed in American hospitals every single day and year. And the economics, approaching $30 billion. And that was when our private sector folks were going, on our dime? We're paying for this? What's underneath that iceberg? And so the Leapfrog Group comes forward then in 2001 and creates the first of its surveys on quality, 2001. And so it is amazing to me that now, back in 2013, a year ago, people are going, a renewed focus. It's taking a very long time to move an industry that I love, and I love being a doc. I love being a part of hospital boards. I really get a thrill out of it. I'm the former doc of the AMA, so I'm not, I'm a true believer. I bleed physician blue, if there is such a thing. Red. I did take the courses. But how can we at that point now? Private sector leadership has got to keep the pressure on. And you all just need to be always irritable. Never be unirritable. Always be demanding. But then you're going to also have to be participants in this drama. What are the kind of driving forces? Well, you know them, but I'm going to review them just to make sure you got them. And everybody would say, well, rising costs are really the dominant driver, and they are, and you really do know that those cost curves now are determinant for everything that occurs downstream. Americans are finally beginning to realize, not just the people like you who are smart and involved, but the average Americans are beginning to understand that the economics that we are paying versus our overall quality and outcomes really don't match. We are such an outlier in the amount that we are spending. That is just unbelievable that we could be that far out and that far down. It just doesn't make sense. What is this money being spent on? And that is the question Americans are asking. We are now seeing very much the major payer in healthcare, our federal government. This was a slide that was done a long time ago. This is the Congressional Budget Office analysis when President Bush II was in office. And I wish I could do the Texas twang that he had, but he would go around here and say, ladies and gentlemen, we got a Social Security problem here in America. And the CBO, the CBO said, no, dude. Well, actually, I don't think they called the president dude, but it's probably more like, Mr. President, we don't have a Social Security problem. What you've got is a Medicaid and Medicare problem. And the growth of that curve continues to be really problematic. And as a result, this becomes, and there's no way that anybody will ever be able to visualize a tax increase in America's political dynamic today that will ever be able to compensate that. So now we're at least happy that there may be some changes. In fact, we see a news article recently, good news. Medicare's hospital trust fund appears flush, and we won't go broke until 2030. Everybody relax, return to your homes, all is well. But unfortunately, one of the commissioners, Robert Reischauer, who's pretty sharp, as soon as the report came out, said, wait 1 minute, folks, let's don't go crazy here. So you might be tempted to conclude that it's healing its maladies, but that would not be, I love the way that these economists talk about, it wouldn't be a prudent, I would quote, it's not a prudent conclusion. It is still fiscally unsustainable, and spending will grow faster than workers' earnings and GDP, from 3.5% to 5.6% by 24. So it is still problematic. We are seeing a lot of reports in the media that say that the cost curve is starting to come down, and that we're not seeing some of the the rise in costs that we were seeing before. But nobody can explain it. What's clearly happening is a major part has to do with the recessions. This is letting us see exactly what's happening. Each of the yellow bars are recessions. And so every time we've had a recession in America, healthcare spending has come down, very predictably. People don't use discretionary dollars when there is a recession. But that's not all of it. There's still something else that must be going on. And what's, I think, really going on also is the tools in the toolbox that the private sector has been using to deal with costs. And any of you as employers know that you've got health insurance benefits where you've demanded that your insurance carriers are doing everything in their power to keep these costs down. Medical necessity review, hospital bed day management, readmission management, value-based technology assessments, value-based benefit design, performance assessment, pharmacy management. We're throwing everything we have at it. And it may start to be somewhat effective. In the old days, when you did all these things, you'd piss everybody off. Everybody. You start dealing with changing your networks, or you start demanding that physicians or hospitals demonstrate why Mrs. Jones should get the 55th MRI, even though she's glowing in the dark, you know, and you'd be held to pay. And if you were an insurance company, and all of a sudden the benefits manager from the employer would be calling you on the phone, well, people are mad and you're doing all these terrible things, and it's just stop. And now the CFO of the company is calling the benefits manager and going, you better shut up, because we can't afford that. And so we're throwing everything. But here's what's really going on, and this is the hard part. What's also happening is we're shifting costs. You can't put any more costs on the large employer. You damn sure can't put any more costs on the small business owner. You can't put any more costs on the federal Medicare budget, because it's done. You really can't put any more money on the Medicaid budget, because every state governor is going berserk. If you look at a curve, and I should have put it up there, but I can do it more dramatically standing here. This curve for K through 12 education looks just like that. The curve for Medicaid expenditure looks just like that. It's a direct mirror image of each other. We are mortgaging our children's education and their future, paying for health care costs at the state level. You can't pile any more on the state. The only place you can go for more money is to Mrs. Jones on 5th and Maple Street. And the out-of-pocket cost, the green, versus wages. Anybody believe that the black line is going to go up anytime soon to compensate for the amount of economics that Mrs. Jones is paying out of pocket? It ain't going to happen. The average American is in the middle of that vice. This is a curve on the average total out-of-pocket spending between 2000 and 2010, 44% higher. So when we start to think now about where is the money going to come from, the money is coming from Mrs. Jones, not some faceless corporation, not some unknown, nameless health insurance company. It's coming from the neighbors. And this takes on a real immediacy like never before. The bad news is that what's really about to happen for the cost curve is that the largest portion or contribution to cost is unit cost, the price of things. And there is a whole dynamic now going on in the healthcare industry, especially as hospitals consolidate and large physician groups consolidate. We're getting real monopsony inside of the marketplace. And you're getting health insurance companies consolidate. Everybody is consolidating down, and it's a real power game. But what's really also happening is that hospitals are buying up physician practices, in particular practices like oncology. So these guys that used to be oncologists on the outpatient side are now moving on the inpatient side. And things that were being paid or charged as outpatient, same service being charged a super high premium because they're being done as inpatients. And as more and more power by the hospitals occurs, that the insurance companies can't fight against that, because if you're not in their network, then and it starts to go round and round in circles. This is not an indictment on hospitals. Let me be very clear. It's the nature of the game. It's how it's played. It's not an indictment on insurance companies. It's not an indictment on hospitals. It's not an indictment on physicians. It's just what's going on. And what I'm getting to you in all of these messy things is we have to have a conversation about how this is going to work and how we're going to deal with it. But at the end of the day, what we didn't want to see happen was to have ambulatory procedures being charged at that rate now being same service. The only thing different is that he got charged, the patient had a wristband on. Once the magical hospital wristband went around that doggone arm, all of a sudden we're winding up paying more money. How are we going to deal with that? That becomes a job for big boys and big girls, and that's you in this room. Number two, innovation. What's really going on that was exciting about trying to keep the cost down, it's happening in a context where there's this relentless innovation. Healthcare, for those of you that are not in the healthcare business, is one of the interesting industries. Everything new costs more than what happened before. Try to buy an iPad or an iPod. You know, I bought my iPod years and years ago, and it cost a bazillion. It was like, you know, mortgage the house, right? Now you walk in the store and they say, oh man, just take it, get out of here. I tried to buy a DVR the other day. I mean, you know, man, come on, man. It costs us, just take it, get the inventory off the shelf. Innovation seems to drive costs down everywhere. We're in the middle, the beginning of the genomic revolution. This is going to be the growth in molecular and diagnostic genetic testing. It is huge growth. But what that means is incredible complexity. The more complex we understand and the more our capacity on genomics grows, the number of facts per decision grows hugely, logarithmically. The only problem is what didn't grow was our brain. So we're just as dumb as we were before, and we've got to make all of those decisions, which is really important. So not only do we have some really expensive stuff pouring into the system, and lots of it, we don't know how to make the decisions to use that stuff intelligently. And now the technology has gotten so good that there's something called next generation sequencing of the genome. The technology can actually make it possible that it is affordable to sequence whole humongous amounts of Jennifer. Only Jennifer. But here's the deal. We can tell you a whole lot about you, Jennifer, and have no idea what any of the information means. So guess what your doc is going to do? We have to investigate. You could have fascinoma number 1, triviality number 2, or remote possibility number 3. Who knows? So guess what? You're going into the hospital to get an MRI, a this, and we're going to spend $1 bazillion in a minute on chasing fascinomas that we have no idea. Here's what's really scary. This is a fundamental American ethical dilemma that big boys and big girls have got to make sure that you understand. And there is no place to have a rational conversation about what's on that chart, on that page, other than a place like the Connecticut Health Council. Places where people have formed an infrastructure for conversation with intelligent people. This is a drug for not only treating, but curing a terrible illness called hepatitis C. And we actually have a drug now that will cure it. Not manage it over a long time, we can cure it. It costs ultimately $100,000 when you add it all in. $100,000 per person to get this drug. Why does it cost $100,000? Because they decided it was going to cost $100,000. The pricing on these drugs is completely, has no reality to anything. But they decided they're going to price it at $100,000. And what that means, ultimately, is that it could raise the amount the U.S. spends on prescription drugs. It will double from $300 billion to $600 billion just because of this one drug. Huge issue. And here's what makes it even more complicated. Oh, by the way, it's also just one of many specialty drugs. These new kinds of drugs, which account for less than 1% of all prescriptions, but a fourth of all spending. So pharmacy students in the back, I want to make sure I got something in here for you from St. Joe's. So anyway, beware. Now, here's the deal. Who gets hepatitis C? Overwhelmingly large numbers of them are IV drug abusers. And who insures them? Ultimately, public sector. So I told you about the governor already mortgaging the budget for K through 12 because of health care. What do you think this is getting ready to do to the budgets in every state Medicaid agency around the country? This is an important conversation. Do we deny people suffering this drug that works? What do we do and how do we handle it? I like to leave these little messy things around because it's kind of important. So we have innovation all over the place. That ear, 3D printing. 3D printing. We're in the decade of the brain now. We have new robotics and telehealth, really exciting things. I'm the new president-elect of the American Telemedicine Association. I have to tell you, the stuff in telehealth is huge. For example, we're trying to move hospital care to nursing home and nursing home to home. That requires the ability to connect with telehealth as a fundamental capacity to do that. Now we're seeing employers are offering more telemedicine options in 2015. We think there could be a $6 billion in healthcare savings, according to the report. So lots of stuff happening on the innovation side. Unfortunately, the care quality side still sucks. We don't use what we buy very well. And by the way, I want to say it again, I love doctors. I love hospitals. I'm proud. They're not bad guys and bad women. These are not the devil. These are not terrible people. It's just that this stuff is hard. I showed you the Air is Human in 2000. It was followed in 2001 with something called Crossing the Quality Chasm. Those of you that have a pencil and a piece of paper, write down to Crossing the Quality Chasm. I want you to read that. Go online and pick it up and read it. You will never find a better analysis. Even though, and by the way, yes, it's 2001. Don't get all freaked out because it's old. So is Shakespeare. Mozart still sounds good. Give me a break. And if you don't like him, play some Duke Ellington. So, Crossing the Quality Chasm was another one that basically says what the title says. We have a chasm in the quality of care. It was all recently updated in 2012 that tells us that this series, now we're up to $750 billion in waste in assets in America because of poor quality. But this one really got me, and this was in July. Hospital patients no safer today, 15 years after the Air is Human report that I just showed you a moment ago. And so we have real issues. But this also is important. The private sector insurers do at least a better job of making sure that their patients that are in the hospital get better care than if you don't have private insurance, which is also a little bit concerning. But it says something about the attentiveness with which the private sector is doing what it's doing. But this is the last in this series I wanted to show you, and this is an interesting, finally. America's organized medicine societies have come together under the banner Choosing Wisely. And they have finally said, hey, guess what? We do stuff we shouldn't do. You think? But 30% of care delivered in the United States is duplicative or unnecessary, according to, the docs. 30%. And so finally, they are not only admitting it, but the good news is maybe changing the culture of medicine to get at it. The next context is preventable chronic illness. And this really, really is of concern. I love this slide. Watch this. This is the best slide that I have in the whole thing. There is a storm of preventable chronic illness washing over a delivery system that we cannot afford. Isn't that good? Thank you very much. I did that. Actually, if you like it, I did it. If you don't, my assistant did it. But the point being is, look at the curve of preventable chronic illness. One of the things that you need to be really, really attentive to is how many people smoke in the great state of Connecticut. How many people get exercise other than getting up and going to work in the great state of Connecticut? How many people are obese? How many people are diabetic? How many people have the fundamental risk factors for a preventable illness? You are paying a huge bill for preventable illness. The magnitude of it is overwhelming. And the medical care system is more than happy to throw the most expensive assets in the world at it. So what you will see is absolutely, if you go to America's Health Rankings, and I do want you to go to that, so you should write down www.americashealthrankings.org. My young staff people hate it when I go www. Because it makes me sound like an old fogey. I say www to give you time to get your pencil out. And you can write down America's Health Rankings. You're number 7, though, so you're pretty good compared to other states. Connecticut actually is a healthier state than most other states in the country. But we will list for you, out of 20-plus measures, which are very broad, what's going on. But here's the deal. If you try to get a public conversation about the things that are killing you in your county, it is very difficult to do it. If you try to organize community groups and so forth, but the Chamber of Commerce is always willing to have a golf tournament for the Little Sisters of the St. Elsewhere. And who could be against the Little Sisters of the St. Elsewhere? But are the Little Sisters of the St. Elsewhere focused on the fundamental things that are causing unnecessary hospitalization and emergency room visits by the people that you're paying the bill for? Are they really focused on the fundamental things that you really got to get done? Probably not. So there needs to be a data-driven conversation that you have to lead through the Chamber of Commerce, through the civic association, through the mechanisms of power that's focusing in on a data-driven community engagement around health. And I really can't push that enough. So you'll see the things. We are living longer in America. Death rates for heart disease are going down. Death rates for cancer are going down. Go ahead, America. We kicked cancer's butt. We kicked heart disease butt. Death rates are going down. Yes, they are. But guess what? The number of people with those diseases are going up. And they're going to live forever. And you can't afford it. It's better that we go ahead and try to eliminate the problem on the front end. Private sector, business leadership, if there's anything I can say to you today that I want you to get more, you've got to get your head in the game on this. And you guys are phoning it in. So if you want to keep paying for it, go ahead. Fragmentation in care delivery is the last big context for me. And that is, as we are living longer with chronic illness, it means we need a lot of stuff. A lot of it is in medical. It's medically necessary social support. And so somebody's got to put the puzzle together. So you get these people who are, like this woman who I took care of, who had a chronic illness. She had diabetes that wasn't diagnosed, led to a peripheral nerve disease, causing her to live in a wheelchair. She had high blood pressure, wasn't diagnosed, gave her congestive heart failure. That's why I have the blood pressure cup up there. She had 3-4 doctors, none of whom were connected by any common information system. So people were over-treating her, people duplicating medication, no connection at all. We discharged her to home, didn't pay attention that, like so many seniors, she lived alone. And in her community, the Meals on Wheels program, see the refrigerator with wheels on it? I did that. I'm so proud. We do try to do Meals on Wheels. It's hard. The Meals on Wheels program was cut back in her town, so she wasn't getting a hot meal, so she wasn't eating. The home health care aid program was cut back, so there was nobody to transfer her from wheelchair bed to bed and back and forth, so her hind parts broke down. She got an ulcer. She couldn't fight off the ulcer because she wasn't eating, so she was catabolic. We told her to come back to the hospital 3 Wednesdays at 1 o'clock, except the mobile van that carries wheelchairs doesn't run Wednesdays at 1 o'clock. So she missed her appointment. So now she's sitting up in the apartment, sick, septic, scared, miserable, a great American woman, lovely lady, by herself, alone and isolated in America of 2013, back then. We discharged, we sent her, she came back to the ER by ambulance. We redid everything that we had done before and more. She represents the reason why your Medicare budget is broke, because the leading cost curve for Medicare is readmissions back to the hospital 30 days after admission for congestive heart failure. This is the story. The Little Sisters of the St. Elsewhere golf tournament, if it doesn't deal with Meals on Wheels, not sexy, Meals on Wheels, then we're missing the boat. And this is the kind of data-driven conversation we have to have. So as we go forward in the future, the organizing framework for everybody to kind of get involved is, we're looking at the triple aim. This is actually a pretty good deal. This is Don Berwick's picture, good guy when he was running something called the IHI, and it was basically everybody can get involved around those three principles: improve the health of the population, reduce the per capita cost of care, and enhance the patient experience with care. And that's what everybody is really trying to push forward to. So this Crossing the Quality Chasm report I talked about gives a pretty good blueprint. This is where we get almost a theology that says, what are our goals? We want safe, effective, timely, efficient, equitable, and patient-centered care. That patient-centered is key. We want decisions made based on best science, safety as a system property, decreased waste, cooperation among clinicians, anticipation of patient needs, patients as the source of control, care based on continuous healing relationship, customization based on the patient's needs and values, shared knowledge, and the free flow of information. This is 2001. And this is still the blueprint today. So if you had to have a little checklist about how well we're doing, check those things off and then see where we are. Ultimately, it's about data. And that's what's really exciting. That today, we are now in healthcare in the era of big data and analytics, just like all the other industries in American life. So our challenge is, how do we solve the aggregation problems and turn data into knowledge, and then knowledge into judgment that takes us where we want to go? Well, it turns out there are a whole lot of other people now who have decided to invade healthcare. We don't own it anymore. And a bunch of 22-year-old kids are going to ultimately be the ones that are going to drive through this thing. So this is just an example of some of these 22-year-old kids who have been given like a mountain of money. I don't know how much that is, but according to the news report in Fortune, a mountain of money from Google. Who are throwing Google's assets and data assets. There are a bunch of people who are coming now out of Wall Street who are partnering with people from the Defense Department and from these online Facebooks and so forth, who are combining to be able to not only do big data, but also big analytics. So I want you to take the data that I mentioned from Merck's Health Rankings and you put it into play. But here's what we're actually now starting to be able to solve. And this is actually being done in real time in America today. Taking the data that's generated by people, their delivery system engagement, prevention and wellness, and being able to take claims, lab, and pharmacy data. We were always pretty good at being able to pull that stuff together and tell a story, a novel, being able to tell a story about Joanne, and be able to say that Joanne is a 23-year-old, perfect, she's a 23-year-old woman who, in this case, is in super great health. But other stories about my patient, who is a 60-year-old African-American woman with hypertension and diabetes, who should have gotten something. And guess what? Our data says she didn't get a mammogram. And then you send out a Hallmark card, and she still didn't get the mammogram. And then you send another one. Then you finally pick up the phone, and you call and say you didn't get your mammogram. And then, like other people that we've had, she sends a note that says to us, "Dear Dr. Tuckson, people told me to get my mammogram. I didn't get it. I finally did get it. I got good news and bad news. The bad news is I do have breast cancer. The good news is we've caught it in time. Thanks to God and you all, I'm going to live the rest of my life disease-free." So it's exciting to have the ability to take that data. Now we're being able to add health risk assessment, health screenings, electronic medical record, health information exchange, biometric device data, mobile apps, coaching data, care, all of this stuff. Pull it all together, analyze it, liquefy it, make it liquid, make it useful, run algorithmic rules on it, and be able to really get involved now with innovative personal interventions. Now, this is happening. It's not happening as fast as it should or as completely as it should, mainly because we are not doing very well in America today in creating a common taxonomy for data, common rules, common glossaries. We are still woefully inadequate. Why are we woefully inadequate? It's because of a huge political issue on the part of the economic incentives for hospitals and delivery systems again. And they write write letters regularly to congressmen telling the Office of the National Coordinator, please don't be so mean to the poor hospitals and make them do a whole bunch of stuff. Or please don't make the doctors, so the AMA is saying, back off, our people aren't ready yet. And the reason I'm saying that is not because I don't like the hospitals, and I know we got people from the Connecticut Hospital Association here, who, by the way, are terrific. And the Connecticut hospitals are terrific. And if anybody gets the impression I'm trying to beat up on the hospitals, I'm not, because I like them, and I think they're praiseworthy. My point, though, is that to err is human was 1999. That's why I went through all that trouble for all those slides. 1999. Crossing the quality chasm was 2000. Come on, man. Is that the sports thing? Come on, man. And so if I wasn't such if I don't get angry enough, you know, if we don't get angry enough, we will let this thing slide another 10 years. No, we have to get at this, and you've got to keep the pressure on so that that crap stops. Technical term, crap. There's lots of great new information now for you as employers. The data is very good now about being able to create these kinds of interactive heat maps. You used to get reports back in a 3-ring binder, like about 50 pages long, and you go pouring through it. Man, that stuff is so yesterday. Now you can have interactive data that will give you a heat map and say, for this particular company, what's driving trend and what's happening. And so it turns out diabetes. And they have plants in like 8 different places across the country. And now you realize that it's not every plant that's driving their cost. It's like Northeast Wisconsin, you know, like cheese, bad for you. Who knew? Damn. Wow. You know, and of this company's diabetics, you can drill into the people in northern Wisconsin and find out how many of those people actually have a primary care doctor, how many of them got the interventions they were supposed to get. You can then drill further, and this is what really gets exciting, is how many of the people there, and I should have left it up there a little second, but is how many of them were empty nesters, how many of those were over 20, how many of them were over 30. In other words, what are the demographic characteristics of these people so that you can start to zero in and program on them. Instead of giving everybody in the company, here's our anti-diabetes booklet, now you be well. You now start to go, no. It's you, dude. and people like you. And we're going after people like you and not wasting time on poor Joanne, who's only 23 years old. The same thing we're using in that data is to deliver to the delivery system. And now what's getting exciting is, hopefully, and by the way, you guys have got challenges here in great state of Connecticut, unlike your peers in the Northeast, around creating health information exchanges. Data that can flow and unify a horribly fragmented delivery system and pull it all together, and then take that data that I talked about, liquefying it and dropping that liquefied combined data into the delivery system so that they can have what I like to call actionable intelligence. Intelligence that helps doctors make the right decision, because it's hard. There's no point in saying, doctors, you suck. Well, okay, good, now what? You know, I went into medicine to do good. I went into medicine to do right. It's kind of hard to manage through all the complexities we have. So can we give them all that data and information so that when the patient walks in the door, there's an alert that says, okay, Mrs. Jones is coming in today, and she's got some really complicated fascinomas, and this is what you need to know. I can tell you what diagnostic procedures you're ordering that you shouldn't. I can tell you what facilities you're using that are driving up your costs. I can connect to public. In other words, giving people data at the point of care, and that's what's exciting. And we're now finding lots of innovative things, like the people at Optum and Mayo Clinic, strange bedfellows. Why is Optum and Mayo Clinic coming together? To create new research hypotheses for improving the quality of care and turning medical care into a learning laboratory. Very interesting kinds of stuff to be able to do. And then finally, what's really also happening is that we're taking that same data I talked about and now running multivariate testing to identify what do we know about how Mrs. Jones thinks. I love this whole idea of the doctor-patient relationship. It's what I grew up on. And when I say the doctor-patient relationship, halos come out. Gabriel parts the clouds. It's one of the cornerstones of Western civilization, the sanctity of this relationship between a physician and their patient. And it should be a cornerstone of Western civilization. The Hippocratic Oath and all that sort of thing. This is really important stuff. But guess what? In the real world of today, there are a gazillion other people that are going to be involved in that relationship. Patients are going to have a lot of people helping them to make appropriate choices and decisions. So we now know what Mrs. Jones needs to know. We actually know who needs to know it, that Mrs. Jones needs to know it. We know what she needs to know. Now the question is, how does she want to know it? When I was Commissioner of Health in D.C., we'd spend $1 billion on these brochures. We would put 5 colors, beautifully bound, pass it out to everybody. Now you just be well, and I'll see you later. Who's going to read it? But does everybody need the same information the same way? So we live in this fantastic new world. People are different, and they have so many new tools, brought to us by the wireless and broadband technological revolution. So now you know we have the ubiquitous internet email capabilities. So I can communicate with my mom, the only way I can communicate with my mother. She will not speak to anyone except through her email. Mom, what are you doing? I'm sending more dirty jokes to a wider group of people than ever before. Thank you, Mom. Our new mobile smartphones and personal digital devices with its texting. If I want to talk to my knucklehead son, Lance, he will not talk to anyone. He will not. I used to call him, no answer. Call him, no answer. Check the bill, paid it, call him, no answer. Then one day words came across my phone. I had never seen words on my phone before. I said words back, words came right back. I said words, words came back. Picked up the phone and called him, no answer. Yes, no, send money. Straightforward, easy to communicate. You can tell from my presentation, I need semicolons. I can't do texting. It doesn't work for me. I got too much to say. I'm sorry. Very different. You can have these mobile apps now that are connected, so you can have people that say, I'm ready to lose weight, and this guy now has a plan, and what can you do? Connect to a social network. And we are learning something very interesting in healthcare. Your social network probably has more to do with your healthcare decisions than your geographical network. You tell your boys or your girls, hey, I'm about to lose weight, and this is my goal, and you let everybody know it, and you're very transparent, and you set up your plan, you know, and you report on it on a regular basis. You connect that stuff up to your Fitbit or some other device, and all of a sudden now you got a whole network of information that's recording it. But then, if you're really lucky, you can take all that stuff, and when you're not making the progress you wanted to make, or you got a question, you can call your insurance company and connect to a coach. And your coach can be on the phone saying, hey, how you doing, Ray? Good to talk to you. And I'm happy to talk to you about your goals there. But by the way, I'm looking at a screen of all of your health stuff because all this information is flowing together. And I kind of noticed that you didn't get your hemoglobin A1C3 monitored recently. So we'll talk about what you want to talk about, but then we're going to talk about what I want to talk about. And you're starting to connect this together. Do you see what can happen? You see the power of this? This is extremely important. So as we facilitate our social networking and we do our selfies and we kind of think of this kind of weird, I kind of get excited because, yeah, well, what that means is that that camera is so damn good that you actually can have a real conversation with your physician. And the resolving power of the camera is so good that the doc can actually start to realize that, oh my Lord, yes, you should come right in. You know, or more importantly, oh man, that's nothing. Keep your kid at home. Don't go to the ER. Don't spend the money. And above all, cook your family some dinner tonight. Right? Which is really what this is about. That's what's really important. Now, you, private sector and people that pay the bills, we got to start to realize how we're going to spend our money. Are we going to spend our money in the emergency room, or are we going to reimburse this? And that becomes the real thing for you. The second thing that's happening in this revolution of giving us how we want it, the way we want it, is this incredible revolution in sensor-based technologies. The largest source of data in the world today is sensor-based technology-driven data. It is an absolute sea change in the way the world works. And so now, you can have things like a smart digital Band-Aid that literally can either say, because it can read temperature and humidity, that you put the Band-Aid on now and it's like saying to the nurse, excuse me, I'm infected, as opposed to just being a dressing. You can actually have it transmit pulse, respiratory rate, and so forth. So it goes to the cardiologist's smartphone. So maybe now you don't have to be in the intensive care unit, but you can actually be someplace else getting a signal sent to the doc's smartphone while he's on the golf course, and it's like, oh, gotta go. Different ways of connecting through, very exciting. And then you can do your remote blood pressure monitoring. Connect it up to your iPad. Here's the issue going forward. Fascinating stuff. But now, so you've got Amazon creating a whole new wearable medical device store. You've got Apple now connecting regulated medical devices, such as glucose monitoring, so that they can connect it into your doctor's system. Very interesting stuff. This is all, by the way, and they had a glitch in the release of the release of the new iPhone. But as soon as they'll fix it, because that's Apple, right? It's just, okay, there was a glitch. They feel sad, but it's not like, I was like, well, we quit. We won't do it. By tomorrow, they'll have it fixed. That's going to be one of the features, this new health kit feature of the new Apple capacity, whole new capability. Here is the issue. If you decide to make something that has medical implications, there's an organization of the American government that wants to speak to you called the FDA. Excuse me, Patricia, but this thing that you are doing to the American people, does it work? Is it reliable? Are you about to kill a bunch of people? We're just curious. And so now you've got, in the smart reporters have gone and looked at the logbook, because it's public, of who has visited the FDA lately. Oh, Google, Apple, Amazon, they're all walking into the FDA, signaling where they are headed as a company. But this is the funny thing, was the co-founder of Google. Health is just so heavily regulated, it's just a painful business to be in. Well, excuse me, dude, but it's okay in your other business if the little app doesn't work. It's inconvenient. This is called death. So I'm sorry if we're bothering you. But we'd like to know. So this is like, you can't read the small print. So I just took this right off of my iPhone. This is a medical calculator app that somebody did. And it says medical calculators is a set of medical calculators for doctors, nurses, technologists, and students, including absolute neutrophil account, acidosis compensation, adjusted body weight, anion gap, APGAR scores, arterial blood content. And then it says, oh, by the way, this is for entertainment purposes only. So, hey, FDA, you don't have to worry about us because we were just playing. No. If they think that that's going to slide, they're out of their mind. So, but here's the thing. Now you're going to have consumers having access to a whole new kind of variety of stuff. The selling and distribution of things is where internet, obviously changed the world with Amazon and eBay. It changed the world in the intersection of information and social relationships. It changes also now the internet inside of things, like Nike with your running shoe, but also Ford. This is really cool. Car tech firms are working together to provide internet apps. Ford is introducing wellness apps. Silicon Valley, Detroit, battling over the future of the internet health-connected car. Really interesting. So now, though, what's going to happen is the internet inside of us. Now there's a company called Proteus. Very interesting people. See that little wafer, the smaller than the size of a pencil? That is an ingestible, FDA-approved wafer that you can manufacture so cheaply that you can put it inside of every pill in America and not really make that much of a difference. You put that wafer inside of the pill, and then you swallow it, and what happens is your gastric acid turns it into a battery, and it signals the exact dose and name of the medicine that you just swallowed. And then it sends a signal to a little monitor that you can put on your arm, and it will let you know now that your mother in St. Louis, whom you're worried about, it will tell us that your mama, she took her medicine every day, on time or not. She doubled up or tripled up because she got confused and she didn't know what she was doing. So you can tell, you will know everything that's going on. Plus, you can combine that and combine it with, it's also just like your regular smartphone, it has an accelerometer on it, positioned it. So now you know how often she got up, how often she didn't get up, whether she's just sitting around all day or not, and you can combine all this data together. The internet inside of us changes an awful lot. So that's kind of very exciting. And then lastly, in this revolution of personal information stuff is information on your genomics. And now we're going to add this very incredibly impersonal genomic stuff. Except here's the problem. The companies that are manufacturing that, this lady got her DNA to test about 3 direct-to-consumer companies, and all 3 results were different. So now we've got to worry about what that means, and that's very important. I'm going to start to end up here, but and get a couple minutes of questions, but let me just sort of hit a few things. One is, there are a lot of people who are now worried about what I just showed you, because people are beginning to be concerned that there's this much data floating around that ties together so much of your life with your health. And either people can be excited about integrating health into your life, or can be sad about the confluence of it, and who knows it. And then there's this, the safety of data breaching. This is really concerning. You can see the frequency with which we're seeing this happening. But here's interesting. Your medical record is worth more to hackers than your credit card. And that's what they believe. And just the other day, we had the FBI now warn the industry that the industry is under attack by the crazy people. And so I don't know why politicians are not running for office on, I guarantee America that I personally will stamp out hacking and protect your personal records, whether it's financial or others. This is like an amazing, under-talked about, under-attended, no, I'm going to kick Iraq's butt, get you elected, but protecting all of the stuff that really means something for you doesn't seem to be. So if anybody's running for office, I just gave you the keys to the kingdom, and I want to be appointed whatever there is to be appointed. Here's the issue as we close out. All of this stuff is swirling around. And it's all fun and it's all interesting. But if I end where I sort of started out, which is, did the people who shared our time and space live or prematurely die, and the quality of that survival? The question is how to turn all that's happening into human cognition. How do we make it change the way we behave? And that's really what's fundamental. There are a bunch of people now who are writing very interesting books thinking about human motivation, whether it's B.J. Fogg at Stanford, who just got picked up by Walgreens, I think, to become the intellectual brain for Walgreens transformation with customers to be a health company as opposed to a pharmacy company. People like Daniel Pink and so forth. So you can see all these people here. But bottom line is, you should start paying attention, if I were you, to what's being written about human motivation, because we've got to get better at it. Angelina Jolie was a remarkable story, and one that ought to be a bellwether for all Americans. She made a decision, as you know. Here's this glamorous, world-famous superstar woman who makes her money on her beauty and her physical appearance. And she had this diagnosis of breast cancer and made a decision to have prophylactic breast mastectomies. Now, she based that on a genetic test. Not a test that says you have a certain thing, but a test based on statistical probabilities of getting a certain thing. You got that? It wasn't that she had a test that said, you should get this prophylactic breast mastectomy because, no, your statistical probability based on your genetic profile says so and so and so. Now let me ask you a question. How many people do you know have had a course in statistics recently? At all. How many Americans do you think are prepared to have a probabilistic conversation with their physicians? How many physicians do you think are prepared to have a conversation with their patients about statistical probabilistic determinations? Do you understand the dilemma? We have a real issue going forward. She had the best advice that any human being will ever have. She could call anybody on the phone and talk to them as long as she wanted to get the answers that she needed to have for her. What is your K through 12 education like in the great state of Connecticut? How many of the kids that are coming into maturity in your state are prepared? Who talks to the school system about the real issues of an adult living in the modern world? I don't think the people in the school system have a clue about what's going to be expected of their children when they graduate in a couple of years. I don't think any of them understand that slide of the two people and the cost curve coming out of the consumer's pocket. What do you think those kids are, the area of the most important and impactful economic and other decision-making they will have in their lives if it isn't healthcare, if it isn't their health? If we don't go in and get the attention of our society about what's coming on, skating to where the puck is going to be, there won't be anybody. And unfortunately, the private sector is going to get left holding the bag for the economics, and it will screw up our economic competitiveness in an increasingly global economy. These are very clear breadcrumbs, ladies and gentlemen. But unfortunately, despite their clarity, there is such an absence of leadership and action as to be frightening. And that's why I wanted to come and be with you today. So my last slide is this terrific book. And it's really not all that great, but the point of it is that it's called The Doctor in the Mirror that I wrote, and the reason that I wrote it was because people are not making the choices they need to make. We've got the information, but we have all kinds of excuses and barriers. So I'm asking people to look in the mirror, and you'll see the best doctor you'll ever meet. After all, who knows you better than you, who makes more decisions every day that affect your health than you, and after all, who loves you more than you. And so we have to do that not only for ourselves, but our society. So this is a time of great volatility in every element of healthcare. If I had more time, I would go on and talk to you about the changes in reimbursement and how the reimbursement model is changing. And finally, we're going to get away from fee-for-service and pay doctors based on the outcomes of care, the value of what they deliver. This is transformative. Unfortunately, we are not quite where we need to be on that yet. It's still halfway. Those of you who are in this room who have anything to do with purchasing decisions for healthcare for your company, you need to put the pressure valve on, turn the pressure up on getting faster to value-based reimbursement. We've got to go faster and faster, because as long as we have a fee-for-service reimbursement system where we pay for piecework, we will get piecework. You must demand value. So we're moving forward in that regard. We're seeing now changes in the delivery system to have more accountable care organizations, these groupings of doctors who are working together to achieve this overall total value for all of the population that's enrolled in their care. That's going to be important. But that will not happen unless the money flows with it. And that's the rate limiting step, is money. And you in this room have a lot to say about money. Move the money and demand the change. And the only other thing I would have said if I had a little bit more time would have been that that I think you all are just really terrific. And I want you to be prepared to follow the leadership of this great organization, the people that are thinking about a vision for what they want the Connecticut Health Council to be. These are very ambitious people who are running this organization, and for this room to be this packed gives great hope and promise that we can decide not to wait for government, not to wait for politics, not to wait for medical organizations and specialty societies and hospital organizations to take leadership. Six Sigma and all that occurred, we need you to be the ones to push. It's in your enlightened self-interest, but it's also in the interest of the community that you have been so blessed to benefit from. Thank you all very much.
expensive pharmaceuticals. I think it was Sovaldi you talked about, Gilead's drug,
Yep.
and how it costs the astounding $80,000. Can you actually talk about how the price of those innovative pharmaceuticals can be a cost savings relative to the cost of care of these terrible diseases?
So the question here is that, and it's a great question, and I appreciate the urge for balance as we look at it. I was trying to get that in saying that, and I want to be real clear in terms of the comments that I made about Sovaldi, was that this is a very difficult conversation to have, and we have to have it, because you've got to put a lot of money in on it on the front end. It is, at the end of the day, the thesis of her point, which is legitimate, if I understand it, is that, that over time, because you are avoiding the hospitalizations and the ancillary costs of treating a chronic illness over a long period of time, that it is possible that you can save money as well. And so it is an interesting calculus. And the question then becomes is, and what people are working through now is, how do you make that calculus work so that you can actually afford across the board? So can you segment the people that get the drug, and if they wait until near the, you're at least demonstrating a certain amount of symptomatology that, and that you kind of say, okay, you're really in the deep doo-doo group. Let's give you that drug, and we think for that particular spectrum of the population that that will be a cost savings, as opposed to everybody just, the first day you have it, you just hammer it away. And those are the kinds of calculations that you are asking Aaron to be made. And that's why I can come back to, though, is that these are the tough kind of adult conversations that societies have to have. And so where everybody is upset, some people are, is, well, wait a minute now, are you actually ethically prepared as a society to say to a person with hepatitis C, you have to wait till you're damn near in deep doo-doo before you get it? And now, wait a minute, what kind of society would do that? Versus, well, wait a minute, but I can't, where do you want me to get the money? So in other words, where do you want me to get the front end money? Before I save the money, where do you want me to get the front end money? And then they say, okay, well, fine, you want it. The tax increase for the Sovaldi tax will be, you know, in the next election, and the society will say, wait a minute, you can't do that. Well, then what are you going to take it away from? So it's a complicated formula. The issue isn't so much Sovaldi as it is that there are 5 other drugs like it coming down the road. So we're going to face this over, and this is just the first wave of those kinds of difficult choices. And we as a society are going to have to start to say there's certain things. In other words, what you're getting to, ladies and gentlemen, and this is not the thing that you are supposed to say in polite company, everybody can't have everything all the time. Now that's just, now, I don't want any reporters saying Tuckson, because this poor guy, Zeke Emanuel, you know, I think came out and said something offhand one day and got killed because he was saying about maybe it isn't so good to live past 75 or something. Now next time somebody's going to say Tuckson said let him die. That's the way it works on Fox News. Yeah, Tuckson said let him die. Wait a minute, hold on, there's a whole lot of stuff here, folks. So anyway, my point only is that how do you make those choices? And where do those choices get made? And that's really the kind of question. Next issue. Thank you very much. That's a great question. Somebody, anyway, you guys decide. Anybody didn't get called on?
Yeah, well, so here's the question. As I look at other healthcare systems in other countries, you kind of come down to the conclusions that they've made decisions about end-of-life care. And, you know, so what do you think the solution is in this country? Because I see in Europe, you know, a lot of things that we do, they don't do. And that saves a lot of money.
Our culture is, obviously, our cultures are very different. Other societies are more than prepared to wait for the MRI for 3 weeks. You know, okay, you're not supposed to get it. Like, they don't have the expectation you get it tomorrow. You know, yes, there are things that you can have and things you won't have. In the UK, there's an organization called NICE, which is which is kind of a weird name because a lot of times people think they're not very nice, but they are the people who decide whether or not the new drug or the new technology has proven that it has enough cost effectiveness to be worth the expenditure of the government's money to pay for it. And they're really tough. Now, they're not, the people that work for nights aren't going, let them die. You can't have it. You know, I'll find every reason why you just die. That's not who they are. These are not Scrooge. They're people, though, who have to make tough decisions. In the United States, when we had the health reform bill, and there was a little group called PCORI, the Patient-Centered Outcome Research Institute, that was in the bill to look at the evidence of whether things work. And guess what the Congress decided to do? Deliberately and vocally. The one thing you can't look at is cost. So we can look at the science, but you better not look at cost, because we don't want government bureaucrats or managed care executives to kill grandma. And that was it. So you can't even look at cost when we start to do these things in America today. At the end of the day, what I guess to answer your question, I guess from my perspective, is the cultures are very different about our willingness to wait. The cultures are different about whether or not everybody should have everything all the time. And at the end of the day, they are making much more decisions about the end-of-life care, because the financial incentives are not there for the delivery system to just take you all the way out. The money is spent at the end of life, and docs in this country, because they're so well-meaning, and we're trained so much that death is failure. Death is failure. Jesus, they died. Oh man, I suck. You cannot die. We will, and whatever it takes, but then there's that philosophy, but then there's the economics. Because you feel you got these intensive care unit beds. And we know from the Dartmouth Atlas work at Dartmouth, if you build it, it will be filled. Absolutely, you build it, they'll fill it. So you got the economic incentive. But at the end of the day, the last thing, just to not make this so doggone highfalutin, I could do a survey. I'm not going to ask you to confess in front of others. But I could do a survey right now and know that at least half of y'all have not done your end-of-life plan. And of those who say they have done it, have not told their families. And so I guarantee you that when it's time for you, you may have thought you did some kind of end-of-life planning, but nobody knows your wishes, and especially not crazy cousin Sue, who lives in Idaho, and who will fly in and be screaming at the rest of the family, like, how dare you kill Mama? And Mama is going, would you let me go? I'm sick of this. I'm in misery. But no, because of something else. My point being is, until you have that conversation, we don't have, so would you just do this for me, please, ladies and gentlemen in the room, because obviously my friend Dan is my new best friend. Dan is a wonderful guy. He wants to make sure, would you just take care of the end-of-life plan, please, and have a conference call with everybody, including crazy Sister Sue, and everybody on the phone so they know what you want. I faced this with my own family, and I lost my son, my oldest son, and I'm glad we had the conversation, and I lost my son, but I tell you what, my son's heart is in a truck driver, father of 2 kids. His lungs are with a school teacher. His pancreas, I mean, I got the list. They sent me the list. I know all the people that are walking around. Let me end with this one story, I'll tell you, which is really amazing. And if y'all, and then some have to leave, maybe you can walk out and then maybe they can take one more. But there was this, it just makes me think about this story. It still kills me, this story. There's a kid, inner city Philadelphia, died unexpectedly, violence and trauma. And he was an organ donor. And years later, his mother tracked down where his heart wound up. And she found herself in Appalachia. And she knocks on the door in Appalachia. And the person who answers the door, beard, guy, belly, blue coveralls. I mean, I'm not just, but I mean Appalachia guy, right? Definitely not inner city Philadelphia guy, okay? I'm stereotyping on all sides here, so I mean, this is an equal opportunity get in trouble story. But, typical inner city mama and typical Appalachia guy. Okay, and he opens the door and she stares at him. They just don't say a word. They just look at each other. And finally, with the most gentle gait, the man steps towards the woman, grabs her, pulls her to his chest, and said, "Listen to your son." This was a theme on collaboration, and I couldn't miss the opportunity. Is that not the essence of collaboration? Ladies and gentlemen, when it comes to whether we shall live or die and the quality of that survival, this is the highest calling of our humanity. So let's transform all of our knowledge, judgment, experience, financial wealth, and capacity for leadership into that kind of dream. Thank you all.
Thank you, Dr. Tuckson, for that phenomenal presentation. And I'm still touched by that last story, so I hope I can get through some of the things I want to express to close out the meeting. But first, let's give one more round of applause to Dr. Tuckson. And also, I have to thank again our sponsors, United Healthcare and Optum. We really, truly appreciate your wonderful support in bringing Dr. Tuckson to us. Specifically with United Healthcare, I have to thank again Jim Bedard and Craig LaFiandra. They were so helpful in the planning of this program, and we can see from the success how helpful they were to all of us. Also, I want to recognize our media sponsors, Fox Connecticut Media Group and the Hartford Current Media Group. We truly appreciate your efforts. In addition, I just have to recognize a few more people, some colleagues of mine from the Alliance. To put on a program like this, it takes a lot of teamwork, and I want to recognize Laura Dinnan-Harbour, our Director of Investor Events, Brian Boyer, our Vice President of Communications, Marketing and Media Relations, and Nancy Wheeler, our Vice President of Investor Relations. Thank you so much. And I don't want any of you to leave without me making sure I let you know about the upcoming programs that we have for the remaining 2014 year. We have two great programs coming up in October at the New Haven Lawn Club. We have Jim Wadley, who's the acting interim CEO of Access Health Connecticut. He will be our keynote speaker. That program will begin at 8 a.m., very similar format to this particular program. And in December, we have Dr. Robert Blendon coming back to Connecticut. As a reminder to all of you, he was one of our first keynote speakers for the Connecticut Health Council. He will be coming back here to the Hartford Marriott. That program will be at 12 noon, so just keep that in time in your mind, because it's a little different from what we normally do, but both programs will be phenomenal. Mentioning the October program is sponsored by Connecticut, and the December program is sponsored by Hartford Pilgrim Health. And in 2015, I'm in the beginning process of planning some additional programs. We hope to be starting January off with a program on behavioral health, where you will be bringing in a national speaker, so that should be a very exciting topic and a very intense topic for all of us to learn about. And before I leave, I want to remind everybody that Protein Science is here today offering a flu block clinic. They're down the hall in Marriott Room B, so if you want to take some time and get your flu shot so we all stay healthy and keep our healthcare costs down, that would be great. They will be here until 11:30 a.m. And with that, I conclude the program. I thank all of you for coming, and I look forward to seeing you at some upcoming plans.